Okay, so I'm going to do this thyroid PowerPoint as a recorded lecture, so it gives us a little bit more time in class to discuss some of the other uh, agenda items that we have. And this is not a long PowerPoint. It's not a too complex topic, so this should not take very long. It's a pretty short video. So we're going to talk about thyroid disease, and the objectives for this talk is to explain the function of the thyroid gland and associated hormones. We want to recognize signs and symptoms of undiagnosed hypo and hyperthyroidism, and hopefully can differentiate between those two, and then identify treatment options for both hypo and hyperthyroidism. And an objective that's not listed here is also we want to discuss implications for the dental hygienist. What is that? Does anything actually affect your treatment as a dental hygienist if you have a patient in your chair that's hyper or hypothyroid? So the hormones, the endocrine system is a collection of glands that produce hormones that regulate body metabolism, growth and development, tissue function, sexual function, reproduction, sleep, mood, and really a host of things, because all these different glands produce various hormones and they just have a myriad of different functions. So the glands, if they are producing the correct amount of hormone, then everything is sort of functioning smoothly and doing what it's supposed to do. If the glands are malfunctioning somehow and not producing the right amount of hormone, either too much or too little, then there's some kind of a disease development that affects some kind of or many aspects of life. So those hormones are released from the glands and they're sent through the bloodstream to the various tissues. So for example, here in this picture, it talks about the hypothalamus, and your textbook talks about the hypothalamus developing the thyroid hormones, but really the anterior lobe of the pituitary gland is where the thyroid hormones that we're going to talk about are coming from. So I'm not sure why this textbook and other textbooks say different things, but you're not going to get tested on it. I suppose it's all sort of one area of the body, but that is something that I noticed was different from this textbook and other textbooks. So thyroid function. So the thyroid is located on the front of the neck, kind of a butterfly-shaped gland. We feel it in our EOIO, and what can help you identify it is when you're about mid-throat or mid-neck, have your patient swallow, and your thyroid gland kind of goes up, and that'll kind of help you feel actually where it is. If nothing's going on with a thyroid gland, it can be very difficult to feel. I mean, you literally probably won't even know what you're trying to feel. If something is going on with the thyroid gland, you might feel a lump, you might feel enlarged, squishy tissue. You might see enlargement with your eyes and not even have to feel it. But if everything is normal, you may not feel anything at all. So a lot of times we're like, I don't even know what I'm feeling for, but that's because probably the thyroid gland is normal and healthy. So thyroid gland hormones regulate metabolic rate. So that's the speed at which cells perform their function. So the thyroid hormones really have an effect on things like blood pressure, growth and development, body temperature, very important for carbohydrate, protein, and fat metabolism. So the thyroid has a lot of important functions. There are a couple different hormones that we're going to talk about. Thyroxine or T4, we kind of say T4, T3. These are the thyroid hormones. T4 is the main thyroid hormone. It's the major hormone secreted by the thyroid gland. But then it's going to get synthesized. The T4 is going to get synthesized to T3, which is actually what our tissues use to have their functions. It's actually the hormone that they use to do whatever they need the thyroid hormone to do. But it requires iodine. So T4 is going to use iodine to synthesize and become T3. And then the T3 is going to enter the target cells, bind to receptors, and become an active form and have an actual effect on the body. Both T4 and T3 are highly protein-bound hormones. So there is actually very, very little free and unbound hormone thyroid floating around in the body available for a biologic effect. So you could say T3 is fairly potent because there's not very much free and there's not very much required in order to get a biological effect. So at the target tissue, T4 is converted to T3, then it enters the tissue and it has its effect. So about 97% of T3 is derived from T4. So that's from that synthesis process where it goes from T4 to T3. And then the remaining 13% is synthesized in the thyroid gland. Iodine is required to synthesize T4. And we get our iodine predominantly through our iodized salt in our diet. Once released into the bloodstream, thyroid hormones can exit in the can exist in the bound to protein or unbound form. But like I said, they're highly, highly protein bound. So you can see you have very, very little amount that's not bound that's actually having its effect on the body. So thyroid, so more about the hormones. We have something called thyroid stimulating hormone, TSH, and this is actually released from, this is your hypothalamus up here, and then we have the pituitary gland, we have the anterior lobe and the posterior lobe, and it's in the anterior lobe where the THS is released. So perhaps the confusion, you know, I'm not a thyroid expert and I'd have to look into this, but perhaps it's created more in the hypothalamus and released out of the pituitary. You know, I'm not sure. You're not going to get tested on it, so you don't have to be, well, actually you might get tested, like you might have, I think actually there are test questions that ask where the THS is released from, and that would be your pituitary gland. So you'd want to know that for a test. So you do want to know that, I think it's important basically to know that the hypothalamus and the pituitary gland are involved with the release of thyroid stimulating hormone. And then if you want to get real specific, the pituitary gland is what actually releases the THS. It's a little confusing, I will admit. So thyroid stimulating hormone, it comes from the anterior lobe of the pituitary gland, stimulates release of T4. So the amount of TSH that you have in the bloodstream is going to dictate how much T4 you have, and how much T4 you have will of course dictate your level of T3. So synthesis and secretion of the thyroid hormones is sort of dependent on TSH. It's all sort of, and it's what they call a negative feedback loop, which means the amount is released depending on how much is in the bloodstream. So if the T4 levels fall, then more TSH is going to be released. If T4 levels are high, then less TSH will be released. So it takes a blood test to measure unbound T4 and TSH. That's how they decide if somebody has a thyroid disorder. And the book doesn't talk about this, but I just know this from like my own experience. And some of you may also be familiar with this, especially if anybody has a thyroid condition. But they've naturopaths are really have really pushed for testing both free or unbound T4 and T3, because they say that the testing for thyroid, unless it's really off, somebody can have a thyroid condition that's like maybe mild and it doesn't show up so good in the way that they test for it in their traditional blood tests. And so I have heard many, especially naturopathic physicians, really encourage patients to, if they're going to be tested for thyroid function, to test all of them, TSH, T4, and T3 for the unbound. But traditionally, and the textbook just says, they'll test for T4, TSH. If either of those are low or high out of the range, then that indicates to them either a hypo or hyper. So in a traditional sort of way, if we're learning kind of more what mainstream medicine might talk about, you're considered hyperthyroid if you have increased blood levels of T4 and decreased blood levels of TSH. And you're considered hypothyroid if your T4 is low and your TSH is high. So what that's basically saying is if you're hyper, you have lots of T4 in the blood, lots of ability to make T3, which is your active. That's what's actually having effect. So since your T4 is high, you probably have too much T3 is what the outcome would be for hyperthyroidism. And then your TSH levels would be decreased because your body's like, I don't need to produce TSH. There's plenty of T4. Alternatively, if you're hypothyroid, you don't have a lot of T4. So you don't have a lot of T3, you're not synthesizing a lot of T3, and your body's like pumping out the TSH saying, I'm trying to make T4, I'm trying to stimulate T4, and it's not working. And so that's the hypothyroidism. All right, so goiters, insufficient hormone production can make the gland enlarged. So here you can see a very large goiter or tumor, most commonly caused by not enough dietary iodine. These are not super common in America because we tend to have plenty of dietary iodine, but you can see this more in other countries. But it's still, we've had patients in the clinic with goiters before, or tumors. I think people might have nodules too that might not always look, like this large, but this is rare in the US. Another cause is inflammation from an autoimmune condition called Hashimoto's disease. So it's important for you to remember that Hashimoto's is thyroid and it's autoimmune. And that is an underactive thyroid. And then an enlarged thyroid can also be, like I said, nodules or a cancerous tumor. Okay. My throat is so dry from leftover from my little sickness. But anyways, okay. So I have to excuse my raspy voice. So the etiology of hyperthyroidism, it's the most common type. The most common type of hyperthyroidism is called Graves' disease. And with Graves' disease, this is also an autoimmune disease. And with Graves' disease, the body has produced antibodies against its own organ. So it's attacking its own organ, and it begins to destroy the thyroid. And when a person is experiencing hyperthyroidism, they'll often feel sweaty, nervous, sensitive to heat, fast heart rate. Everything is kind of accelerated, right? So the metabolism is sort of up on higher gear. They're hot. They might feel clammy. They tend to be thinner people. They might have sort of like a fast kind of heightened sort of hyper way of being, and a faster heart rate. They may have weight loss. And then bulging eyes, that is something that can happen, and it's from a buildup of tissue. It's inflammation and a buildup of tissue from behind the eyes. And here's an image. These are a couple of very kind of extreme images. but the bulging is a result of inflammation and a buildup of tissue and fat behind the eye socket, and it kind of pushes the eyes forward out of the head and causes them to bulge. So treatments for hyperthyroidism, there's thiamide drugs. The mechanism of action here is to inhibit the thyroid hormone produced by interfering with the incorporation of iodine. So here's a few examples: methimazole, tapazole, or profilthiouracil or PTU. I don't usually see these in, I might have seen methimazole, but I haven't really seen these drugs as commonly in practice. You'll see that the most common drug that you'll see is usually Synthroid or levothyroxine, but these are short-term only. They're not, there's a lot of bad side effects with these. They can reduce white blood cells. And so these are sort of trying to dampen or, stop the thyroid hormone from being overproduced in the body. Then there's radioactive iodine. Patients drink the liquid containing sodium iodine that destroys the overactive thyroid. So this would actually kill the thyroid, and then it's going to put the patient into a hypothyroid, and then they're going to go on thyroid medication for the rest of their life. Then there's just iodine. Lujol solution is 10% potassium iodine and 5% iodine. Let me just make sure that that's actually right. Yeah, that is right. And then this is typically used. Lujol solution is actually over the counter. And then there had been talk of not, I think it still is over the counter, but there had been talk of pulling it from being over the counter because apparently it's a necessary ingredient in the creation of methamphetamines, in the production of methamphetamines. Did not know that until I read that in the textbook, but that I know you can still get Lujol solution because there's some homeopathic purposes for Lujol solution that I've read about, and you can still get it online. So I know it's still available, but anyways, predominantly this has been used before in patients that are in a thyroid storm. This is a life-threatening condition where we probably would never see a patient in this specific acute condition. They would be either on their way to the hospital or in the hospital if they are in a thyroid storm, kind of an acute condition. For hypothyroidism, this is deficiency in secretion of T4 and then therefore, of course, T3 from the thyroid gland. Their elevated blood levels of TSH are going to be high, obviously, because the body's trying to compensate, but it's not working. It's more common in women, and this is going to be the opposite of hyper. So for hypo, we're going to have cold. You can think kind of like cold, slower. Typically people may have more of a weight. They might gain weight as opposed to losing weight. So it's kind of like colder and slower instead of like hot and fast. That's how I always kind of differentiate between hyper and hypo. So cold intolerance, weakness, tiredness, fatigue, hoarseness, constipation, aches and pains, and oftentimes there can be some weight issues. And then myxedema is another term for severely advanced hypothyroidism, mostly in older patients, but that is a term that you want to become familiar with because I've seen that on other, I've seen that like in board review questions where they've talked about myxedema. So kind of synonymize, that's not the word, I don't know how to say it, make a synonym of myxedema and hypothyroidism is what I'm trying to say. And so treatment for thyroid replacement, there's thyroid USP or Armor, which is not really used. It can cause allergic reactions. It's thyroid derived from animal sources. Levothyroxine or Synthroid is, and there's various generic drugs because it's been off patent for a long time. This is one of the most common drugs used in America, and you'll see it quite often. For therapeutic purposes, synthetic T4 is used. So it's a synthetic T4 because then the body can change it to T3. And the T4 stays active in the blood longer. It has a longer half-life of 7 days as opposed to T3, which has a half-life of a day. Some adverse effects of too much overdosing on medication can be irritability, overdosing of hypothyroid, or like say someone's taking too high of a dose of Synthroid. They can have irritability, nervousness, insomnia, headaches, palpitations, weight loss. So it's almost like pushing them into hyperthyroidism. They can also be at a risk for congestive heart failure, fluid retention, and myocardial infarction or a heart attack. So things that we need to know as dental hygienists, there's no special precaution to follow when you're treating a patient who is a well-controlled thyroid patient with thyroid disease. If they have a steady medication that they've been taking for a long time, there's really nothing specific that you have to worry about. If you're unsure if your patient is stable or the patient states that they've been adjusting their thyroid medication and you're concerned about it, you do want to do a medical consult before administering local anesthetic, especially. Epinephrine is limited to 2 cartridges if somebody is a documented hyperthyroid. If they're hypothyroid and they're stable, you don't have to adjust anything with local anesthetic. And then epinephrine is severely contraindicated, it's contraindicated. That's just a blanket statement. You don't have to say severely contraindicated. You just don't use it in patients that are in thyroid storm. But again, like I said, this is highly unlikely you'd have a patient in your chair with that acute condition. They'd likely be in the hospital. But good to know. And that is it. So that's thyroid. And if you have any questions, ask me when we're in class. Thanks, guys.